Welcome back to Ethically Sourced. This week, we're continuing our conversation talking about the equitable and ethical distribution of COVID-19 vaccines. We rejoin our conversation with Dr. Kevin Simon, already in progress. The question remains, is the ethical justification for prioritizing economically worse off racial minorities, is that legal and ethical?
Right.
Now, it is based on some of the epidemiological data that we have, and the fact that these communities have been hit harder, they've been ravaged, in fact, by this vaccine. What are your thoughts?
So it's a great question because, one, we know that race is a social construct, right? So folks who are born in sub-Saharan Africa do not consider themselves inherently black. It's when they migrate somewhere and are told, oh, you're black, that then race becomes a significant factor. And so, unfortunately, in our country, race tends to be paired with a lot of unfortunate circumstances that we deem like, determinants of health, right? So if you are black by identification, what you look like phenotypically, there's a tendency that you may live in a lower income area. You may have higher rates of poverty. And so I think from the data thus far, despite race being socially created, it is impacting those who get coronavirus by worse death, higher hospitalization. So the idea that those who are identifying as Black American, Black Afro-Caribbean, getting the COVID vaccine first does sound reasonable. The challenge here is the precedent that's been set by our history would indicate that it is that same exact group that is going to be the most resistant to being deemed, oh, you want me to first, right? Because it's going to be perceived as, is this experimental? Is this some trick that you're trying to do to me? And so, unfortunately, yes, Black and brown persons should probably receive it first, given the nature of the past, essentially past 11 months that we've seen. Yet, they're going to be the most resistant at receiving the vaccine. And actually, even outside of COVID-19, when we just look at vaccine numbers and distribution and administration, Black and Latinos and adult persons tend to be lower on accepting of vaccines. So now you're saying the group that most often doesn't accept vaccines to now be the first to get a truly new and novel vaccine. It's a hard road to travel for a public health personnel with regards to vaccine distribution.
Yeah, and that's from the perspective of the patient. If you look at it through the lens of policymakers, you're going to have some, they're going to use the phrase reverse discrimination, where they're prioritizing minorities for this.
Right. And unfortunately, things like quote-unquote reverse discrimination to persons of color, that doesn't necessarily sit well, right? So, because you have been discriminating me all these years, all these centuries, now you want me to be the first. And again, a lot of people that I've met, a lot of people that ask questions, will say the phrase like guinea pig, right? I can only offer, I've received it. I have other colleagues who are Black and brown that have received it. But I understand from a policy perspective and also from the evidence, right? Like it is Black and brown persons that are dying more, that are hospitalized more, that are going to ICUs more. I mean, even right now, as we're probably talking, in California, they're running out of ICU beds, right? And if you probably look at the distribution of ethnic diversity, it's probably because there are more Black and brown bodies that are going to those ICUs. So I understand, but it's going to be a hard road. And so it's important for persons like us, Black physicians, to be kind of a sounding board, say, this is actually safe. I've received it, have not had any untoward adverse side effects or reactions. But yeah, the idea, reverse discrimination probably could use better language, but it is appropriate to try and target the population that is most affected when we're talking about distribution of a very important antidote for disease. Yeah.
Yeah. So, but I think about it this way, though. We're fighting this uphill battle. We're going uphill both ways. We're trying to convince populations that have been disproportionately affected that they need this to help decrease their morbidity and mortality. But from a policy perspective, when people at the table don't look like these communities that are being affected,
Right.
what incentivizes them to advocate that these communities receive any sort of preference? So it's kind of it's a double whammy, right? We can't say this, we will give these communities more vaccine for those communities due to the mistrust that the system has built within them to then still not receive that vaccine, right? So it's on the policy front, it's very interesting. And to follow up on that, this group, the National Academies of Sciences, Engineering, and Medicine, they recommended two frameworks to look at. They mentioned first the Social Vulnerability Index, which was developed by the CDC and public health agencies to look at communities affected by natural disasters, hurricanes, earthquakes. It looks at geographic areas of vulnerability based on 15 census variables. And these variables are linked to the disproportionate impact that those communities face at baseline. However, that directly correlates to the communities affected by COVID-19. And those 15 census variables include poverty, education level, the number of personnel in the home, and race. So this Social Vulnerability Index actually incorporates race. And this paper goes on to say that could be a sticking point for those groups that are going to say, hey, we cannot reverse discriminate, or we can't prioritize on the basis of race. However, the caveat that they recommend in this paper recommended a different scoring system that's called the Area Deprivation Index, which is very similar to that Social Vulnerability Index. However, it takes away the demographic, or it takes away the...
Yeah, it doesn't explicitly prioritize based on race.
Exactly right. It takes away that racial category. Therefore, we could hopefully use that to prioritize distribution of the vaccine.
Right. This and I know we're talking about vaccine distribution. This actually is still related to COVID-19. Several months back in the state of Massachusetts, which was looking like California is right now with regards to the number of ICU beds, there was a question, kind of like what we're actually talking about right now with regards to who gets an ICU bed. And in reference to this transparency and why it's important to talk about this, they have come up with a algorithm for who gets a ICU bed, and the algorithm actually didn't incorporate race, but it was a point scale, and if you had more comorbidities, you actually got less points. And so there are folks who are not at the table who say, wait a minute, you're saying if people have heart disease, they're less important to get a ventilator. And so after some rumbling from residents, from attending, Massachusetts actually changed course. So it goes to the point that you had mentioned earlier about like who's at the table, and we need to make sure that we are at these tables, because when there is something that this is important, right, which is vaccinating, a good 60 to 70% of the country, it's important that we're trying to think as equitably as possible, and considering the nuances laden with race, ethnicity, again, things that are socially constructed like race, but unfortunately play a major impact on outcomes. So I think their idea of the Area Deprivation Index is a good one. And again, it's going to be, we're talking a lot in a little academic, exercise here, but how do we translate this to the general public, right? Because the general public's not going to care about, what's ADI, what's SBI,
right?
What are you talking about? Ethical principles. This is the similar to Tuskegee or similar to things that are happening now with regards to OB-GYNs, in jail systems euthanizing women. Like there's an importance here to be able to speak clearly and succinctly to explain why it's important that we get as many people vaccinated as possible, and also secondarily, it's really important that folks who are most vulnerable, and I think that's what I say most often when I'm talking to my family or friends. It's like we're at super high risk with regards to contracting this disease and having worse outcomes from it. And this is why it's important, and why I, feel comfortable getting the vaccine, and why you should feel comfortable getting the vaccine. I think it can get lost in between the academic ivory tower, then to the street level. How do I explain this to a massive number of people?
Yeah, but I don't want it to be lost, like the significance that this opinion piece in JAMA is actually raising this question, which I think it's a great start to the conversation. We've looked thus far on how you received the vaccine, being in the group 1A. Mm-hmm. We looked at the recommendations for distribution of this vaccine. We talked about the potential for prioritizing those that have been worse or affected the worst by this deadly pandemic. But let's take a look at what it's like on the ground, right? I know you were talking earlier about the NBA, because they had a bunch of players in the bubble, right? And they were testing people. What was that? You mind sharing that memo from the NBA?
Yeah, so two parallel stories. So one, we'll do the NFL first. So the NFL, its season's been going on. They're about to ramp up into the playoffs. Every team has been able to get coronavirus or SARS-CoV-2 testing daily, right?
You got to say it correct, or Dr. Drummond's going to send us some hate mail.
I know. That's correct. So they've been testing daily for months, right? Where you have some cities, remember New York City, teachers are asking like, "Hey, can we get tested once a month?" These, NFL players have been getting tested daily. That's one group. The NBA, yes, it had the bubble, right, in beautiful Florida for their playoffs, and now they've restarted their season again. And there was a memo sent out a couple of weeks ago stating, we as the NBPA, National Basketball Players Association, so that's their union, we will not skip the line with regards to getting the COVID-19 vaccine, because we know that the CDC has recommendations and there are different phases, and we are not a part of phase 1A. And that's very important that they put that out there, because they're kind of setting the standard for what it's supposed to look like for a national organization that really does have billions of dollars behind it. How are they going to remain ethical, and how are they going to remain equitable? So I think it's a very important statement by the National Basketball Players Association and the NBA to indicate we're not going to cut the line. And now we segue that to, there are unfortunate stories now about how not NBA or NFL players, but those who are doing quite financially well, figuring out ways to skip ahead of the line and getting the vaccine in the 1A group, even though they don't necessarily belong in that 1A group.
Absolutely. This is ending on this article, which is featured in the Washington Post. I don't want to get sued by mentioning anybody's name, so I'm just going to stick with the Washington Post. And it deals with the story of the title of the article is "Wealthy Donors Received Vaccines Through Florida Nursing Home." And it talks about this nursing home community or company. It's called Morse Life, which I just looked at their website. It offers 5-star senior living. It's in beautiful South Florida, Palm Beach, so I'm sure it's a very elegant retirement community. So essentially what happened down in South Florida were donors to this retirement community received personal invitations from representatives of that community to come down to the nursing home, or they high-end assisted living facility to receive the vaccine ahead of schedule. As Kevin mentioned earlier, over 65 years of age in assisted living communities is Group 1A to receive the vaccine. However, these people did not actually live in these long-term care facilities. And the story is very well documented in the Washington Post. They received a personal invitation, came down, and were able to get vaccinated without waiting in line. Are you surprised, Kevin?
Unfortunately, I am not surprised given the society that we live in. And then also, when you think about that subsection of Group 1A, right, nursing homes, these are some of it. What's actually surprising is the fact that there's somebody within that organization or that nursing facility that works there that said this isn't right, and we're going to somehow get this to the Washington Post. So I applaud whoever that person is, because the reality is when you have folks who are in nursing homes, a fair majority of them, or a fair number of them, I say majority, a fair number of them are going to be folks that have major neurocognitive disorder. So that's like dementia, Parkinson's dementia, Alzheimer's, and may not be able to speak up for themselves and may not be able to recognize if they are or are not getting a vaccine. So the fact that, again, somebody alerted the Post and they've made light of this is important, because it sends a signal to other facilities like this. Don't try and do this, because unfortunately it's going to continue to probably happen. And even I can say at my hospital, if people were asking, I'm getting this vaccine, I live with a partner, can my partner get it, right? And the hospital administration said, no, this is for those who are workers in the hospital, right? It could have very well been that, hey, bring your wife, bring your son, bring your cousin. But then that circumvents the whole point of having different phases. And so, I can speak for myself, right? So my wife is a hospitalist. She works at a different hospital in Boston, who is having the vaccine distributed. But my wife's also pregnant. And so she at this time has not decided to get the vaccine. She may not. I don't know. But it goes to show that we at least for us, we're saying, no, we have to do this in the right fashion. So I did get it. I see a lot of people. She hasn't gotten it, partly due to the pregnancy and wanting to get more information about it. But there's a lot of people who are out there who might say, oh, you know what? I'm a donor to this facility. Let me just fly down on my jet, get it quickly. So again, whoever that person, the whistleblower is from that organization, more power to them, because this is probably happening in more places than we recognize, as tends to be the case when things are profiled in the news. So again, more power to that person.
Yeah, and reading the story, you guys really check it out. Let's hit up a Washington Post about some sponsorship. But it sounds like some of the materials came from the individuals involved themselves. Like they were literally saying, oh, this is how I got vaccinated. They got an invitation. Now they've donated between $45,000 for one case and $75,000 to this senior living home. And one of the people involved was a member of a country club down there in Florida. And he said he didn't think all 300 members of the club were actually invited down to get the vaccine, but that he and his wife applied to get immunized and they were accepted. They went down there and got the vaccine. And it's almost like they kind of bent the rules to the point that these folks didn't even seem to feel bad about what they did. Like almost like they didn't think they did anything wrong.
Right. Yeah, and I know we're probably coming to the end of our episode here, but even thinking about the pictures that you've been seeing of different personnel, right? So again, this whole phase 1A, clinical personnel. I'm not sure how many, United States senators and representatives are doing clinical work, yet you see a lot of pictures of them receiving the vaccine. Now, part of that could be they're trying to demonstrate demonstrate for their constituents this is safe. I can't argue with that. Yet, just looking at what's written by the CDC, it did not seem to suggest that policymakers and or politicians are accounted for in that first wave. But I understand they are elected officials, and so again, if they represent a district in the Bronx or they represent a district in Chicago, perhaps by getting it, they are demonstrating to their constituents, hey, this is safe, and you're a vulnerable population. So I understand it, but again, this is where the ethics come in, this is a great question that we've been trying to talk about here today.
Yeah, absolutely, and just the dichotomy of seeing. That's why I made a big deal in the beginning about how they verified you were Group 1A for you to receive the vaccine, right? They kind of knew that you worked at the hospital. It wasn't hard to look up. But the further you get away from that, it gets a little loose, right? We went through the different recommendations for how it was distributed, but those recommendations eventually make it to the state level, and then the state has a lot of say over how they distribute the vaccine to the different counties. So it's really a trickle-down effect. And if you want to get involved and affect change, you can really do it at multiple levels, whether it's at national level with the Advisory Council on Immunization Practices. You can actually look up and see who all is on that organization. You can get involved in the state level or your county level and get involved. So you can be at the table and see what long-term care facility is getting how much of the vaccine, which local pharmacy is going to be administering the vaccine. And then when the vaccine is actually being distributed, how do you verify that the folks that are in Group 1A, Group 1B are actually the folks that are getting the vaccine? Now, it gets tough the more granular you get, but in the absence of regulation, we're going to see more and more situations like this occur.
Right. So I've had an idea that clearly will not come to fruition, but in reference to how we get a lot of people vaccinated, I've actually thought about our current voting apparatus in the United States, and how if you're a Democrat or Republican in a certain district and it's voting time, you get call after call after call after call. I do actually wonder if that would be something that would be reasonable with regards to ensuring as many people that meet the different demographics among the different phases. Would it be appropriate to say, here's a phone call, we're just letting you know that the vaccine's available, you can go to this site to get it? Because again, I think there are going to be a lot of people who get the vaccine, but there's going to be a lot of people who don't get it, who maybe do want it, but aren't connected and don't know how to reach out. So I do think that kind of talking about potentially other strategies that are out there, not to say clearly we're going to go through the different phases, but just some other ideas that I've heard kind of bounced around could potentially be interesting.
Yeah, that's a thought. I think we have a little bit of time for organizations to figure out how to do this. I think this initial rollout was very small and limited in the grand scheme of things, right? It doesn't seem like it because all we see on social media are us and our coworkers getting vaccinated. But compared to the rest of the population, we've still got a long way to go. So this is a test. This is a trial run.
Right.
It's important for folks, if you're in Group 1B, C, or even Group 2, look at your local public health department, look at your state, because that's going to really give you the information you need to find out when and where you can get vaccinated.
Hopefully over time, because we're primarily talking about Pfizer and Moderna. There's a third vaccine being developed by Johnson & Johnson, who I believe will only be one injection that's required. So hopefully, more vaccines are able to be manufactured, and that we really can get, an overwhelming majority of people that need to be vaccinated, so that way we can, resume somewhat of a normal life with regards to, socially engaging the people again in the ways that we wanted to, that we couldn't do this holiday season.
So it's been a couple weeks since Kevin and I recorded this episode. And since then, a lot has changed with regards to COVID-19 vaccine distribution. Namely, the headlines across the country that are telling of thousands of doses of the COVID-19 vaccines that are being discarded because there aren't enough patients that are showing up to vaccinate. Basically, the story goes that so many doses are allocated for X number of patients, whether in a long-term care facility or emergency department or hospital. And at the end of the day, if all those doses are unused, then they've been defrosted and they're no longer good to make it for another administration opportunity. So all these doses end up in the trash can, which is a pretty egregious waste of such a precious resource. We waited so long to have this available, and unfortunately now we're inefficient when it comes to administering these vaccinations. There's not yet a solid number of how many doses of COVID-19 vaccines are being discarded or wasted across the United States since the rollout began. But the World Health Organization back in 2005 actually had some numbers that up to 50% of the vaccines that are released globally each year end up discarded because of supply chain issues. That's not enough freezer space or issues with transportation. The mechanisms and infrastructure for dissemination of this COVID-19 vaccine, they need to adapt faster than they are currently. Thankfully, certain health systems and state health departments have begun to adapt and change their methodology for administering these vaccinations. We have situations where, like in New York, where Governor Cuomo actually loosened the rules that initially designated COVID-19 vaccines to frontline healthcare workers and residents of retirement homes. And he kind of loosened these rules to allow leftover vaccinations to be provided to other folks that don't necessarily meet the 1A, maybe 1B classification system. There's actually an article in NBC News talks about an emergency department in Ohio where a team came to provide vaccinations. There weren't enough patients that showed up to be vaccinated. There was a request made from the personnel there in the emergency department to vaccinate other at-risk patients or people that desired the vaccines. The group that was administering the vaccines said, no, this is against our policy, right? So they acted according to their standard operating procedure. This story talks about an emergency medicine physician who went up the chain of command at the hospital to obtain permission to have these doses of vaccine administered. And by the time he went up the chain of command, the doses had expired. The team that was administering the vaccination had departed. So nationally, we're starting to see that this vaccine rollout across the U.S. has been victim of poor planning and this distribution system that needs to be revamped and reworked to ensure that we are efficiently administering the doses of this vaccine that we do have. Thanks for tuning in for this week's episode. Hopefully you enjoyed the conversation. We will definitely continue to monitor this developing situation as more and more COVID-19 vaccinations become available. Dr. Simon, thank you so much for joining us, and we'll definitely be talking with you soon.
Yeah, Dr. Bradley, anytime.
Thank you for joining us for another edition of Ethically Sourced, a supplement of the Black Doctors Podcast, where we focus on presenting information and resources that can proactively improve the care our patients receive. We hope that by generating these discussions on clinical medical ethics and culturally competent care, we will have a positive impact on the lives of patients that look like us.